I've been with home health for 4 years, and within the last 3 months, I have now taken over the wound care coordinator position. And so that's what I'm doing now, is trying to incorporate all the best of the best.
I have been in wound care for over 15 years. I do believe I've worked every facet of wound care that there is to offer. Evidence-based medicine to me is I want to see the white papers and I want to see the research that's been done, and I want to review it for myself without having any type of undue influence from the prospective parties. Just send it to me, let me read over it, let me review it by myself without any pressure, and then I have to see the proof in the pudding. I have to use it myself, I have to try it myself, and if I don't see the results that this white paper's saying, I'm not going to use it.
Evidence, basically. I mean, that all in itself, it's there. You have so many people trying to tell you, well, this works and this works. Well, show me it works. Let me see case studies, let me see the journals, and then let me try it out for myself. I want it to see that it works. I don't want someone telling me it works.
I think the most common in the area of wound care is going to be your journal analysis and your case studies, because that's what's most prominent. Personally, all of the meta-analysis, and it goes way over my head. I'll be real honest. And it's hard for me to, I understand what they're saying, and I take that into consideration, but hardcore evidence to me is if I use it on my patient in the real world, this is what I get. Because you have a very canned, most meta-analysis, a lot of them, the settings are very controlled, and real world is more important to me.
Because that's who we're taking care of, is the real world. I mean, we're not taking care of a piece of paper. We're not taking care of pictures. We're taking care of people. And there are patients. And, like you were saying, it's the proof in the pudding that's what's important.
And I've participated in clinical studies and clinical trials within the outpatient wound care setting. It is very difficult to maintain the standards that are required in order to keep those patients in the clinical study. So I know how important it is to have those clinical studies, but I also know real world, real life, real time people, it may work and it may not work like the clinical study says. The collagen-based dressings, I guess I'm a little more lenient on, as far as I might give them an extra week or two before I'm going to see their therapy. If I'm going to use an engineered skin graft, a bioengineered skin replacement, the expense of those involved in treatment, the expense for the patient with their co-pays and everything else, I'm not going to give it the chance to fail.
If it does fail, what damage can be done if they do fail? It's a little less on this side than it is on this side, so I'm more, to go this way. And I don't need as much evidence as I would to go over here with the bio.
I think insurance companies are going to try any way that they can to not have to pay for a product. Whether that be documentation, lack of documentation from a pressure on admission, which is in the beginning stages now, to failure to heal more than 10% after 4 weeks, which is in the current LCDs.
But if you really think about it, is it really any different than the last 10 years where we've had to buck the system to get what we needed for our patients? So, see a lot of changes with insurance? Not really. They've been doing it for the last 10 years. So I think it's just going to continue.
We just have to learn to play the game a little differently. Nothing we're not used to.
No.